Welcome, everybody. I am Sarah Searle. I'm a senior manager at BAO, and it's my distinct pleasure today to be moderating this session with Chengetai Ziwa. Chengetai has over 10 years of experience in implementing strategic information systems in the nonprofit sector, and he's experienced in conceptualization, strategic planning, and managing robust M&E systems, both at the local and regional level, and also has experience in customization, management, maintenance, and governance of DHIS2 and mobile data collection platforms across multiple countries. Chengetai is here today to talk to us about the Ready Plus program, which has adopted a DHIS2 Android software-based management information system called Wanda. I love the name. To collect, analyze, and visualize data. The Ready Plus program is aiming to improve access to quality healthcare for adolescents and young people living with HIV through health providers and peer supporters. And in this session, Chengetai is going to walk us through his experiences in designing and rolling out of a DHIS2 Android-based MIS in low-resource settings. With that, I will turn it over to you, Chengetai. Thank you so much for being here with us today. Reminder to folks to please put your questions and answers or comments in the chat or in the Q&A section. We'll have 30 minutes of the presentation and then 15 minutes of Q&A. Thanks so much. Take it away, Chengetai.
Thank you very much, Sarah. So I am going to share with you the work that we have done with Ready Plus in using DHIS2 Android-based data management system in low settings. So just to give you a brief background of what Ready Plus is all about. So READY is an acronym that stands for Resilient, Empowered Adolescents and Young People. And the plus represents or stands for young people that are living with HIV. And the geographical focus is Zimbabwe, Mozambique, Eswatini, and Tanzania. And the targeted population is adolescents and young people who are between the ages of 10 and 24 years and who are living with HIV. The program is implemented through a consortium which is led by Frontline AIDS, and it has got 6 regional or national organizations, and has got an additional 14 community organizations that actually implement the work on the ground. And the goal of the program is to have adolescents and young people that are living with HIV being, number one, resilient, being empowered and knowledgeable, and have the freedom to make healthier choices and access services and commodities. So this program has actually been running for the past 4 years, and now we are moving into what we are calling the phase 2, where we are now scaling up to 3 more countries, which is Zambia, Malawi, and Angola. And this is going to be running for the next 6 years. So just to also give you a background on why we've got the name Wanda. We customized DHIS2 software, and we called it Wanda because this is a youth-led program. What we actually had to do was to hear from the young people themselves what they thought would be a good name for the system, and they chose Wanda, which is actually a name of a transgender activist who was called Wanda Fox. And Wanda Fox was she came from South America. And in recognition of the work that was done then, the young people thought or felt that they would call the system Wanda. So the broader system is used by implementers and community adolescent treatment supporters. So the community adolescent treatment supporters, who are also known as CATS, are the ones that mainly make use of the DHIS2 capture or the Android application. So the question would be, why did we choose to use DHIS2 capture? So the program is aimed at following up on young people who are living with HIV over a period of time, and the main objective is to make sure that the young people are retained within care. So because DHIS2 capture allows clients to be registered, and that data on services and visits are also added to the record, building a history of the client's care over time. This became one of the main reasons why we then chose DHIS2 capture app as the app that we were going to then use to to collect data. The other reason is also because that we are working in mainly in low resource settings across the Eastern and Southern African region, and so we wanted to also use an application that users could use in an area where there's poor or no internet connectivity. And we also wanted to be able to have an application that would facilitate client follow-up, like I've already indicated, and would also allow data reporting and decision making in near real time. The reason because being that we are supporting young people who are living with HIV, but because of their status, they are faced with a number of other challenges, and therefore it is prudent that whenever something is reported, it is actually acted upon on time, so that there's no delay in actually reaching the the young person, and therefore the application was actually able to to support that. And of course the the fact that we also wanted to have an application that can be used across different countries, which also supports different languages. And so maybe just to give you an idea of how the capture app is actually implemented on the ground. So the community adolescent treatment supporters, who are CATS, these are actually young people who are between the ages of 18 and 24. And these young people help to support their peers in ensuring that they adhere to their medicines, in ensuring that they go for their appointments, and also making sure that if they've got any other problems, any other issues that they may be facing, they can then get support through bi-directional referrals. And so these CATS then work closely with the health facilities, and they identify the young people that would have been diagnosed with HIV. And once they identify these young people, they of course work with them and their parents and their caregivers to seek consent for them to be part of the program. So once consent has been obtained, they become registered as part of the program. And once they are part of the program, they then the services that they are receiving are then recorded, through the routine visits that are done by the cats. The cats would therefore, become a bridge between the health facility and the community, so much that if a young person is in the community and they're facing a challenge, the kids would then relay that message to the health facility, and if there's need for the young person to actually go to the facility, then of course again the kids will facilitate that process. And so once they start to get the services, some of the services that they'll get as and when it is relevant would include your viral load. So for example, we want to make sure that young people who are living with HIV and are on ART, they are routinely tested for their viral load as per the country guidelines. And so the kids would then make sure that if they have got an appointment, that appointment is actually fulfilled. And if it is not fulfilled, then they can follow up with with the young person within the community, working in collaboration with the health facility and nurses. Then of course, if they default on their treatment, again the kids would also follow up within the community to try and understand why they are not coming to the health facility. And if, for example, if they give a reason that I've not been coming to the facility because I am tired of taking medicines, probably they started their medicines when they were very young, and now maybe they're transitioning into adulthood. The kids also has the duty to sit down with them, counsel them. And because the kids are also young people who are living with HIV, they can actually then also share experiences on how they would have managed to overcome such issues. Then the fifth thing that they would then do is to then facilitate bi-directional linkages. So when they sitting down with the young person, and they actually then realize that maybe there are things that or there are services that the young person can actually access, which are not available either at the health facility or within their immediate community. The case, because they are already linked with the different stakeholders within that location, they'll then be in a position to actually link the young person to other services. And so just to show you how or probably the interface of the app, the capture app. So we have got what we call the beneficiary in case registration service checker. So like I've already mentioned, the kids, because they are also young people that are living with HIV, but in this case they would have been given some training for them to actually support their peers. But even though they will be supporting their peers, they are also beneficiaries that are actually supported by by the program. So normally what happens is that the implementers are the ones that sort of take care of the kids, and then the kids will then take care of the rest of the beneficiaries. And so the demographic details of the client or the beneficiary are then taken, and we of course make sure that confidentiality is maintained. So we actually have a unique identifier code that we use, which is what we then actually use to track the young people. Then, of course, as part of the services that I've already mentioned, we'll then track the viral load, we'll track the referrals, We also track the services provided, which is mainly your HIV care services, your sexual and reproductive health services, and your psychosocial support services. And of course, we also check, whether the young people are still active or not. So if they are not yet, if they are not active, because maybe they've exited out of the program, for a variety of reasons, it could be because they are going to school and they are going to a place which is actually out of the targeted location, or because they also are out of the age range that we normally support. So because we would normally support up to 24 years. So if they then get up to 25, 26, we then refer them to other programs that would support individuals within that age range. So in terms of how we are managing, or how we try to manage the capture up, we have got over 400 cats in the 4 countries who are actually supporting the peers. So all the 400 cats, we actually assigned a mobile device, and the responsibility of the implementers in the health facilities was to make sure that the devices are managed well and are used for the intended purpose. And this has been done through a very clear protocol. So when the kits are issued out with a device, we also included, or we also involved the caregivers, for them to know that when they see their son or their daughter coming with a phone, it is for work. The work that they'll be doing to support their peers. And so in terms of managing the data and the voice bundles, the implementers would also then take that role. Then we do have another layer of a country lead organization who will then manage the implementing organizations, and the country lead will obviously provide technical oversight on the management of the devices, as well as the management of the application. Then Frontline Aids is a consortium lead, would then provide the overall management to make sure that the capture app is actually working as required, and of course to facilitate the procurement of the devices, and also to make sure that the cats do have the support that they require to actually make use of the application. So after we did the development process, we've used the application. We also wanted to understand if the kids were satisfied with the app that they were using, and also just to understand how to improve the experience. So what we then did was what we went through was to collect client feedback, and the client here would be the kids, and then we to turn that feedback into action, and of course improved the user experience of Wanda. And what we did was we conducted a non-experimental design where we implemented a survey just to understand the various variables that we actually put on the survey. And then the results that we got overall, it showed us that in terms of this, the quality of the system, the young people that we engage in the survey, they scored at least 3.98 out of a 5. And in terms of the speed on the device, it was 4.5. The client confidence, which actually entails how the young people felt confident in terms of making use of the application, and also the support that they would receive from the implementers. They scored that at 3.94. And then we also tried to also discuss or get information from, or data from the key informants, who also corroborated the findings by outlining that essentially the system is quite reliable, and data can be stored at any time and anywhere, which was something which was very key for the program, because we are aiming to be collecting data from young people at any given time, and we didn't want to be restricted or to be limited by structural issues. And then, of course, we do have challenges that we have faced. So one of the main things has been that because we assign the devices to the young people, and they are supposed to keep the device at the house facility. But because some of the areas that they actually visit are quite far, sometimes they then end up going with the device at home, and probably spend maybe 2-3 days with the device, and then only have to come back to the facility to synchronize their data, and of course to do their routine reporting. So one of the main things we faced were that some of the mobile devices got lost, some got stolen, and some could get damaged. We also even realized that, I think, in the process, we sometimes, I think, ended up exposing the young people as well, because when they then go out with the mobile devices, they then became prone to people would then try to take them away from from them. But of course, with the continued awareness that we did, particularly with the caregivers, it also helped in making sure that there was shared responsibility amongst the caregivers or the parents, the kids, and of course the implementers. Then, of course, managing the devices is quite costly because, for example, when we bought the devices, we also had to make sure that these devices would, in a way, be still compatible even after the updates, would have been done. So it would then become a balance between trying to buy a device which would still be compatible, say after 3 or 2 years, but of course trying to get something which is also cost efficient. But on the overall, I think the management of the devices alone, also making sure that they are connected to a mobile device management platform, it was somewhat costly, which is something that we of course took in and tried to see how best to address that. Then, of course, the mobile devices also ended up being used for other purposes, because they are being assigned to young people, and young people sometimes then ended up probably downloading games or using the devices for social media, which was probably not the intended purpose. And one other thing that we also picked up was that in some of the households where young people would be living with the extended family, if they needed to call an uncle or to call an aunt, they ended up also making use of the phone or the device for that purpose. And of course it's something that would be sometimes beyond the control of the young person, because they would have been asked to do so by their parents and their caregivers. And then another challenge is also the time taken to synchronize the data, where, like I've already mentioned, the kids would be moving or would be traveling very long distances, and so they go to an area where there's limited or no network coverage, and by the time they want to then come back and synchronize, some of the problems where that because we would be expecting that data would be stored in the cache, it may then not be found, maybe because in between they would have cleared the cache, and that data would be deleted. So those are some of the challenges that we then noted, particularly when we are working in those low resource settings. Then, of course, what we've learned is that the application actually makes it easy to facilitate bi-directional linkages, in that when the young person goes into the community, then when they're supporting their peers, they then don't need to go to places, and then they are seen, and then the need for another service is actually picked up. But the kids, when they are in the community, they are the ones who actually then identify the need for other services, which is then done by them, and the kids then actually follow up to make sure that that referral service has been provided. Then there's also potential for scale up, and we've actually noted this because, like I've already mentioned, we are trying to go into 3 more countries, and because we are able to make use of the application, across different countries, and making use of different languages, this actually has made it easier, to do. Then, of course, another draw function, another thing that we've learned is the draw functionality of the application, whereby we are able to record data, and we are also able to to communicate amongst the young people within the application to actually follow up on appointments, and also to check whether one is, for example, going to pick up their medication, and if not, what are the reasons, and so on and so forth. Then, of course, we also learned that shared ownership rarely increases responsibility. So when the health facility takes ownership of the device, the caregiver or the parent is also involved, and also the implementer is involved. That is also limit or reduced the number of that were damaged or that were lost, and also you would realize that when the health service provider would be would be asking for the device, the implementer is also asking for the device, that actually put in quite I think quite considerable level of responsibility for the kids to make sure that that device would be kept safe at all times, which also in a way then meant that even the data that was being collected was also kept safe in that manner. Then, of course, the tracking of service uptake over a long period of time, which is one of the key things that we are trying to actually achieve, was actually made possible by the application, and we learned that you can actually go for quite some time when you're actually tracking different services over a period, for for an individual, and then you're actually able to understand how they are, for example, adhering to their medicines, if they've been having some challenges, what sort of challenges they would have had, and how then you can actually inform your programming going forward. And then lastly, how do we move forward? So designing and rolling out of an Android based system is quite challenging. Mainly when you're working in the low resource settings, but it is also rewarding. And we are also looking at possibilities of integration and interoperability of Wanda to try and enhance the user experience. And of course, in order to improve buy-in, we are also trying to see if we can get champions at every level to facilitate the acceptance process of the application as it is being used by the young people. Thank you very much.
Thank you so much, Chengetai. I hope you can hear our virtual applause from our, our audience. That was a really rich presentation, and I loved learning the where the name Wanda came from. I actually was Googling like who Wanda Fox, the transgender activist, was right when you said it. So thanks for sharing that.
Yeah.
There are some great questions in the Q&A. We have about 11 minutes to go through some of them. And, a lot of these questions focus on really what I was thinking about as you shared this experience, maintaining clients in care, minimizing interruption in treatment, et cetera. This is really the name of the game nowadays in HIV programming, right? We know that to achieve epidemic control, we need to do that. And a lot of the questions in the chat are around sort of, you have these great cats who are doing this community outreach to young people, and folks are wondering, if they are referred to a facility for care, how is that loop closed? Are the cats notified in some way that someone has actually, closed a referral or it's like gotten the care that they need? I think people are curious kind of how, this is I think a very perennial health systems constraint, right? This idea of like community facility linkages and how we make sure that we have that bidirectional linkage. So another question along those lines was around if there are any plans in the near future to include automated notifications from service providers. Can you speak just a little bit about sort of like how that loop is closed, or if maybe that's still a pain point for you? I think folks are curious.
Okay. Thank you very much, Sarah, for that. So, in terms of referrals, what normally happens is that when a kid who is in the community refers a young person to a service provider, they actually make sure that that service is actually completed. So it's either if it is within their area of jurisdiction, they are able to actually follow it up and go to the service provider and follow up and check whether the service is being provided. And if it is out of their jurisdiction, what they then normally do is they liaise with the other cats who are in those areas, and then they identify and see how best that young person could be followed up. What also then happens is on the application, we indicate when the referral has been initiated, and then we also then indicate when the referral has been completed. And once it has been completed, there has to be some evidence that it has been completed. So of course we don't get 100% a referral completion, but we always encourage the case to follow up they also are faced with many cases, for example, where where when the young person has been referred for a service, maybe they actually don't get that service. So it's then their role and their duty rather to then make sure that if that service is not available, what other alternative can the young person receive. So yeah, yes, definitely, we try by all means to close the loop, but of course there are cases where we then fail for one or two reasons.
Yeah, of course.
Yeah,
Thanks for
yeah.
sharing that. I think, I'm kind of curious. You had mentioned sort of these learning points and that this, the Wanda system is being implemented in multiple countries. And I saw that you had mentioned there are 400 cats. Do you have any sense of sort of the scale in terms of number of clients that are being worked with?
Okay. So the total number of clients over the four countries is 24,000.
Oh, wow.
Yeah, yeah.
Yeah,
So it's
that's a fairly amazing reach considering how many of the cats you have. So that's great.
yeah, yeah,
Um,
yeah.
Another question in the chat, sort of more on the technology side of things. Curious if any mobile device management software was considered for any of the issues that you had mentioned as kind of the challenges. And this implementer noted that they definitely experienced these issues too. There actually was a fairly robust discussion, I think, either in the Global Digital Health Forum mailing list or on the DHIS2 community listserv recently about mobile device management software. But I wonder if you could share any experiences there, if that's been considered, or if you have any recommendations for that device management.
Yes. So yes, I can share some experiences on that. We actually made use of one mobile device management software, which is called Scale Fusion, like over the past 4 years. But one of the things that we faced, it was nothing to do with the system, but I think it was that it then made the application very difficult for the young people to use. So, for example,
Mm-hmm.
we could remotely lock the device to only work within a specified area, so that when they go outside their jurisdiction, then it was not going to be possible for for them to actually use the phone. But we then ended up getting quite a lot of reports of the young people actually failing to support the peers, maybe because the phone uh, got logged, and they were not able to unlock the phone, or cases where maybe they are supposed to go out of their jurisdiction, maybe because the young person that they're checking and tracing has been reported into to have gone out of that area. So yeah, they I think there were quite a lot of technically it would work, but on the ground it then failed to work practically, because it then meant the implementers would then have to be on the ground all the time, trying to tweak the system and unlock the system. So we ended up just unlocking all the devices to try and avoid some of the challenges that we're facing. We are still trying to see if there's any other way we can do it to make it easier for the young people, but of course also maintaining the work that we were doing. But I think from my personal experience, it probably works very well when such softwares, they work. I think when you are in an organization setup, and you can easily liaise with the people that are actually working with the system. But in our case, where sometimes they then go out of area where there's network coverage, it also means that the software will not work, because it is supposed to be working when there's internet.
Yeah, can you, we only have a few minutes left, but I was wondering if you could speak a little bit about sort of the asynchronous nature of the app when the cats do, exit an area with coverage. Again, I think another perennial problem for many of us who work in sub-Saharan Africa. And I know that the DHIS2 capture app is sort of set up to, like you said, sort of save the data locally, and then when there is coverage to synchronize it. But it sounds like possibly that near real time or that like slight delay is problematic sometimes for this program. Is that true?
Yes, it's very true. There are actually cases where, or instances where, they would then report that the data is actually lost because they would say, "But I've collected the data." But when we then try to look for the data in the system, it is not there. And we would notice that it is probably they would have collected the the data when they are offline. And because it would have taken them, quite some time to then synchronize. Maybe along the way, the data would have been, would have been lost. And of course, we have also had, quite some issues where, when they try to synchronize, they then get quite a lot of errors, which may be linked to internet connectivity, or probably the speed of the internet would be would be very, very, very low, and then in the process they almost end up giving up until someone then actually comes to to assist. So yeah, they I think there's been quite some challenges that we have faced with synchronizing data, particularly in areas. I can give you an area like in Tanzania, in Kagera. There are areas where even your mobile network, it doesn't actually work. So it would mean the young person has to go and collect data offline and then try to find somewhere where they can get some sort of a coverage. But maybe the coverage will then be weak to actually make sure that they synchronize the data. Yeah.
So in 1 minute left, some very big questions around privacy and security. How are you dealing with different, this is a great question, how are you dealing with different country privacy, security laws or requirements? This person is curious if there are any similarities with regards to legal requirements across the 4 countries in which the app is used, and if there's any adjustments that have to be made from location to location.
Yes, so definitely we've actually made some some adjustments, looking at the different requirements per country. I can tell you for a fact that we're actually using a different program in Tanzania as opposed to Eswatini, Mozambique, and Zimbabwe. So we actually have two different programs, and we did that to make sure that we actually satisfy the requirements in Tanzania, and because we also work very closely with the Ministry of Health. They also advise us on what would work and what would not work like in terms of the privacy laws and so on and so forth. So yes, we of course came up with for example, like a unique identifier code that we agreed on, and was based on looking at the like different UICs in the 4 countries. But when we then actually implemented the different ways to make sure that our data is confidential and it is private, we then of course consulted with the local laws.
Yeah, that's a lot to balance. Well, thank you so much, Chengetai. Again, a really rich presentation, and hope you can hear our virtual applause. And thank you everyone for attending and for your great questions.